Thank you very much for the wonderful invitation to be here and this conference. It's very exciting to see this group starting up. So I need to start out. I don't have any conflicts of interest to declare, and I need to be clear that I'm speaking as an individual, and my comments do not represent the official position of CDC. So my outline, I hope to explain to you why I put ME/CFS and post-acute infection syndromes together, and I probably don't have to spend a lot of time on that because the first two speakers kind of made that pretty clear. I'm going to talk briefly about the public health framework for action, some examples of epidemiologic studies, just tiny little vignettes and their contributions. Examples of our education and the importance of partnerships, and then hope to close with just a few closing messages. So first of all, why ME/CFS and post-acute infection syndromes? As been emphasized in the prior talks already, and I think you'll hear it again and again at this conference, a wide variety of infections have been known and recognized to trigger an ME/CFS-like illness, and many patients report an onset following acute illness. But the infection is often unknown or undocumented, and that's why we ended up with this ME/CFS kind of designation. However, there's a striking similarity to the syndromes that follow other known infections: an overlapping symptom profile, a female predominance. They are all chronic, complex illnesses, and the routine tests are often normal. These unexplained post-acute infection syndromes were really just first recognized as a failure to recover from a whole wide variety of infections. We expect most people to either recover or die, right? We don't expect this middle ground of something continuing along. And the core symptoms, you're going to hear these over and over again. They're the same ones: exercise intolerance, activity limitations due to this disproportionate fatigue, neurocognitive problems, sleep problems, and recurrent flu-like symptoms. A wide variety of additional insults or additional symptoms may be present, and some of these are trigger-specific, and you already had a little discussion about this. The SARS-CoV-2 may have some certain other things with it. Each kind of infection may have its own kind of specific symptoms. But the net result is a very heterogeneous picture. Even with SARS-CoV-2, known single insult, there are more than 200 symptoms that the patients report. And these chronic complex illnesses really require symptom management at this point because we don't have an intervention. The ME/CFS and post-acute infection syndromes share many challenges. And the biggest one for physicians is the diagnosis relies on the symptom profile and perhaps a temporal association with an infection if it's known. It requires really good medical care, and I think all ME/CFS physicians are excellent physicians because they have to take into account the medical history, the physical examination, and testing, and know when to stop testing, looking for things. Because what the idea is, you want to identify treatable conditions and illnesses that could contribute to the symptoms. There's a lot of overlap, and these patients have many comorbid conditions. Patients all have difficulty finding healthcare providers that understand their illness. And chronic complex illnesses don't fit into our current clinical frameworks very well. There's no approved drugs for therapy, and the clinical guidance remains at the level of expert opinion because there have not been enough clinical trials to make the evidence-based literature. So when SARS-CoV-2 pandemic occurred and COVID was happening, pretty much the community was anticipating that here we go again. There's going to be a long COVID kind of problem. And it's the silver lining, as Dr. Levine said, out of all of this is I think we're coming together as multiple communities recognizing that we share more problems than not, and they could be better addressed together. And so working, having a clinic that could address all of these conditions would increase the access to multidisciplinary care. And our goal is to empower primary care physicians to at least diagnose and manage these patients, refer them to their appropriate specialties as they need. And clinics could be established that would see the full spectrum of post-infection syndromes and related overlapping conditions. We need to work together to develop case definitions that are appropriate for their use, right? And they could differ between what is helpful clinically and what you want to do for research or surveillance applications. And infection, again, I'm going to say this over and over again, the infection is not always recognized or documented. That doesn't mean it hasn't happened or isn't active. And we, of course, need research to clarify mechanisms of disease. And studies that include all of these groups as comparisons are really essential in order for us to understand similarities and differences. So briefly, public health approach to all of this. We use a lot of epidemiologic studies, and these are done to, primarily document the burden of disease. How much is it in the population? Who gets it? What are the consequences? But we also hope to identify risk factors. That's classic epidemiology, because if you can identify risk factors, that's where you can intervene and prevent. And so that's our goal. And it also generates data that we can use for education and awareness, right? But we need to do this with partnerships. And these partnerships are important to both inform and implement, but it's not, easily separable because a lot of our partners are involved in the epi studies and work together. And probably our most important partner is those with lived experience. They have so much to tell us. But we also need to partner with other government agencies, and this is both at the state and the local level, as well as clinicians and academics. So a few examples of epidemiologic studies. And one that I want to share with you is results that we recently got from the National Health Interview Survey, and the data is from 21 to 22. And the National Health Interview Survey is given to US adults, and it's representative, and we included a question about ME/CFS. Have you been told by a healthcare provider that you have had ME/CFS? And 1.3% of US adults had ME/CFS, had been diagnosed, and still have ME/CFS in the United States. And again, we see the same female predominance in the population. Now, self-report has its limitations. You have to have had a diagnosis by a clinician. The clinician may or may not be correct in their diagnosis. And so we have those limitations, but it does give us a national representative picture right now of what we can call ME/CFS. We did a very different kind of study, and we called it the multi-site clinical assessment of ME/CFS, and this was conducted between 2012, pre-COVID, finished up sort of abruptly because of COVID. And this was a collaboration with ME/CFS clinical experts in the United States. And we relied on their clinical diagnosis of the patients having ME/CFS. And the little stars are where these clinics were located. And this avoided the bias of a case definition. Now, people will say bias, but if you only look at a certain case definition, you might miss other people. And the question was, do these clinics all recognize the same kind of patients, or are there differences in the clinic, in the clinical patterns? And at the time when we studied, there had been very few multi-institutional studies of ME/CFS, so that was a real burning question. We collected standardized information on all of the illness domains of ME/CFS, and this allowed for cross-clinic as well as cross-illness comparison of measures of fatigue and pain and some of the other things. And the data was also used to inform the 2010 IOM case definition. As a result of this, we were also able to share which questionnaires, how our questionnaires worked, and it supported the Common Data Elements Project that is a collaboration with NIH, CDC, and internationally. And we plan to have the biospecimens and data shared through the NIH-funded platform of MAP MECFS and Search MECFS, and this will be a resource for investigators. Shifting again to another project, we collaborated with the Emerging Infections Program at CDC. And this is a relatively high prestige program. So anytime we can get MECFS into programs that are recognized, it is really important. And we included an MECFS project that was designed to be a syndromic surveillance of fatiguing illness. Our goal was to try to understand the early phase of the illness. And as Dr. Levine said, most patients come very late in their illness, so we didn't have a good view of what happens early on. Now, we didn't know that the pandemic was coming, but the pandemic has now given us a whole lot of early cases. And so the study was rapidly modified to include post-COVID MECFS-like illness. The goals of the study, which we call STOP MECFS, is surveillance to optimize protocols for early identification and subgrouping. And it is in collaboration with the California Emerging Infectious Program site, as well as Kaiser Permanente Northern California. And the Kaiser representation is really important. It's a very big managed care organization in the United States, and it has really helped focus their thoughts on MECFS and how to really care for these patients. And so we have a view of MECFS in a managed care organization like Kaiser. And through a sampling and survey approach, they identified that 1.7% of their population met criteria for MECFS. And of those, the majority were diagnosed and were not from COVID. Examples of education and partnership. And this is one of our favorite projects. It's the Long COVID and Fatiguing Illness Recovery Program, and we call it LC and FERP. We couldn't come up with a shorter, cooler name, but we tried. It is a contract with the Family Health Centers of San Diego, which is a federally qualified health center. This is in the United States, sort of a clinic, safety net clinic. People that don't have health care insurance, they provide services and care for. And the goal was to evaluate a multidisciplinary team approach to delivered via telemedicine to see if this could improve care for patients with long COVID, MECFS, and post-infection fatiguing illnesses. And when we started this project, the focus was on the long COVID. And the federally qualified health center said, yes, of course, sure, we'll include MECFS, but we really don't see those patients. After about 6 months of the program, they realized they do see those patients. And so it's, again, once you start thinking about it and looking about it, there's so much to be learned. And our goal is to empower primary care providers in these safety net clinics to provide care. And if we can do that, that will amplify and improve access to care. And so was organized actually as a clinical trial, a demonstration project, because while everybody believes Project ECHO and telemedicine is going to make a big difference, having data to show that it works is, of course, what we want. And so it's organized to have 3 components. The first is a weekly case-based ECHO session, and this is kept only to the providers that are enrolled, very small. A provider presents a case, and depending on the case, then the ECHO program invites a didactic lecture and a panel of experts to discuss the case and help. And so this weekly session needs to be very small and intimate to allow trust and sharing. Then there's a monthly ECHO webinar that's open to everybody, and these are didactic sessions followed by question and answers, and the recording and resources are available to all. And there's finally quarterly courses that offer continuing medical education, and these are also open to all. Each of these are available for 12 weeks. And the comparison for the clinical trial is to look at the patient outcomes of the patients cared for by providers who either were randomized to the weekly ECHO, the webinar, and the course versus only the webinar and the course. And in addition, the outcomes at the clinic are going to be compared to specialty clinic at the University of Washington. And what we learned very much so from this project is the MECFS experience really helped the project. The lived experience experts were included in absolutely every session, and they made a tremendous difference in helping the clinicians understand from the patient's point of view what the patients were going through. They shared their experiences and were able to identify with the problems that the long COVID patients were experiencing. And it really shifted this to be a very patient-centered dialogue. The clinical consultants that all volunteered their time, and we had a tremendous outpouring of support for this, were able to right away emphasize the importance of avoiding post-exertional malaise. And that's something that's often hard to get across. And then they noted that the triggering pathogen is often not known or documented. They shared information on diagnosis and symptom management that they learned from MECFS, and this is available through the MECFS Clinician Coalition that has a very nice website. And they suggested inclusion of the nasal lean test as a way to screen for postural orthostatic hypotension. Another shift now to our Medscape collaboration. Medscape in the US is a really important provider of medical education. They are able to target their advertisements and their educational delivery to their different audiences, and we've asked them to focus on primary care providers. And so we support Medscape to develop the CMEs, and you can see they've picked some really good people like Dr. Systrom and Dr. Bateman. This is our current one that's up. We've done several with them, and this is a much bigger outreach than if CDC created its own content. But CDC does create its own content, and this is available on our website, and we hope that it's useful to people. We have, these are just several of the pages. We have toolkits for patients. We have information targeted for healthcare providers, including their resources for medical students, and as well as a special section on MECFS in children. And I will tell you, those web pages were very controversial, and they only got really well put together through partnerships. And we achieved this through a series of roundtable meetings, 2016, 2018, and then in 2021 we had the last one, and that had to be virtual because of COVID. The other ones were in person. And before the meeting, the contractor had facilitated small group discussions to really focus what the questions were and people's opinions. And even in the small group discussions, we were sure that we had differing points of views, right? We made sure it wasn't all patients or all caregivers or all clinicians or all government. It was a whole variety. And this broad representation in small dialogues really made a difference, because the conversations and the discussion really started to allow people to understand differing point of views and why they may be. And we all need to work together. And so, just my closing messages. MECFS and post-acute infectious syndromes remain poorly understood complex illnesses. First and foremost, clinicians need to listen to and believe their patients. Increased awareness and progress is urgently needed in all of these areas because inability to find health care from providers with an understanding of these illnesses still remains the biggest problem faced by the patients. And progress requires multifaceted collaboration and everybody working together. Illness heterogeneity is a key feature and very inherent in these illnesses, and we can't underestimate the complexity of this. This means that individualized care plans are helpful, and standardized measures of illness characteristics are encouraged to help stratify and focus research questions. And last but not least, the people with lived experience provide invaluable insights and need to be included at every phase, from the beginning of a research project through the end and interpretation as well. So thank you very much.
System, and I thank you all for your excellent talks about the role of CPAT in the management and evaluation of these patients with long COVID. So do you think that we should all do invasive kind of CPAT, or do you think that, at least at my knowledge, the two-day kind of consecutive two-day CPAT is also an important evaluation for this patient? Could you expand a little bit more on this two-day CPAT? How we can do that on our clinical, real-world kind of data? Thank you.
Sure.
No.
If this is on.
Okay.
Is it on?
Yeah.
Okay. Thank you for the question. The good news for Portvo is that you have Dr. Mario Santos, who is setting up invasive CPAT as we speak. So I think that's wonderful. But having said that, I don't think it's for everyone. And I think it really does inform us about the disease and allows us to identify subtypes, as you just heard from Dr. Unger, to perhaps create some precision medicine. But I don't think it's scalable. It's not for everyone. So the two-day CPAT has evolved, I think has been blessed by the CDC. Back in the day, the Betsy Keller Ithaca protocol. So it's non-invasive. And for those of you who aren't aware of it, it's 2 days of day one does an incremental non-invasive CPAT measuring VO2 peak, heart rate, anaerobic threshold, ventilatory anaerobic threshold, and then repeat on day 2. And that's an effort to capture post-exertional malaise, which is probably the most specific amongst our symptoms for ME/CFS and a subset of long COVID. So I think that is much more scalable. We do in Boston sort of a modified, and Yale progeny as well, a non-invasive test that's very simple. I own no stock in this. It's called SHAPE. It's a 3-minute step test with a metabolic part piece, very similar to the non-invasive portion of what I showed you. And it gives you many of the same variables. We're actually using that in a planned randomized clinical trial called LIFT, which is funded by the Open Medicine Foundation in ME/CFS as a major outcome. But that is very scalable. It's something one can do in a primary care office. The metabolic cart costs about $40,000 US. But I see that as having huge potential. Thank you.
Thank you. Well, I remember that you have, if you don't want to put it questions orally, you have in your bags small cards, and you can do it. Please, Dr. Edora. Thank you. Microphone.
Hi, my name is Dora. I'm a physician, and first thing of all, I'm very pleased to be here, and I want to congratulate all of you for this excellent initiative, and I think it's the best that can happen here in Portugal, because as a physician and as a patient, I'm with a long COVID. I think here in Portugal, we don't know anything about long COVID and the consequences and the sequela that this may happen to all of us. And as a physician, and I've been 3 years in the front office of long COVID, assisting to patients. I have 5 times COVID, and I have a long COVID now. I'm asking you, I think it's for you, sorry for my question. It's a question that I think all of us that deal with patients after long COVID and after COVID simply. I didn't heard you mention a manifestation that the COVID by itself has in the heart, the myocarditis and the pleural effusion. It's a complication very dramatic for the patient and for us that deal with that and have to have answers for our patients. You told us about a complication, like the effort, that it's not measurable by echo, simply echo. Correct me if I'm wrong. And when the patients went to the cardiologist, they don't find anything. Okay, you are tired, but it's not by the heart. The heart is no offended by the virus. And when the patient accidentally has a myocarditis, okay, the heart is done. The heart is harmed. And when they are pleural effusion, okay, the heart is harmed. But there's no way the tired, the fatigue, there's no way it's the heart. How do you explain that complication if you know something about it? We heard and we learn a lot with the papers that is published, like it's a spike protein, it's similar to the COVID, that it's a reaction, autoimmunity, a long response, inflammatory complication, but this sounds like, what's your name, sorry?
Unger.
Unger said. Someone recover rapidly and others have recurrences. And these people with affecting the heart, with myocarditis and pleural effusion, probably they don't ever recover. And this is probably the complications. And there are other complications that we saw, the eyes. Yes? COVID, the neuropathy of the COVID in the eyes. It's a target also. Eyes, hearts, and pulmonary complications, and neuropathy complications. Sorry for all of these questions, but I think we have all of this.
Who is going to? David?
Sure, Dr. Levine would love to chime in. Do you want to go first?
You go ahead.
Okay.
Just approach the microphone, yes, please.
Better? Okay. So, no, you had a lot of good questions, really good questions, and obviously, no pun intended, from the heart as a person with lived experience. So we get all of that. My mission in my 20-minute talk was not to cover all of long COVID. It was to point out some of the things that we have found that are common to ME, CFS, and long COVID, in particular in the exercise world. And I think it was said a couple of times by my co-speakers here that what is common is not inflamed heart and pleuritis in the two diseases. That would be particular to long COVID. So anyway, but good questions, and we're happy to try to field them. I think that our approach to both diseases really is to rule out everything under the sun. And the papers, 3 of them that I presented today, buried in the methods, was doing exactly that. And part of it is the invasive CPET helps us do that. I rule out left heart disease with things like the pulmonary capillary wedge pressure, and I rule out pulmonary hypertension. But that isn't the entire story. I think the patients that we're seeing, we do the time-honored history, physical exam, routine labs, and with cardiomyopathy, cardiac markers like troponin as a screening test. And you do that all up front. And the patient population I was focused on was where those things are all negative. So, but there is a ton of discussion to be had about your other questions and, you know, what drives long COVID, what drives the subset of patients with heart disease and pleuritis, what's their prognosis, et cetera. But I'm going to turn to Sue Levine, who's seen 8 billion more patients than I have, and she may have a comment.
Yeah, very well said, David. I mean, I feel that irrespective of organ failure, that the fatigue can be caused by the the pro-inflammatory cytokines that are obviously secreted. I call it like a low-level cytokine storm. That term was in popular use right after COVID hit, that people in the hospital were in cytokine storm, but I feel that the long COVID folks have elevated pro-inflammatory cytokines, and of course that can account for some of the prolonged fatiguing symptoms. In addition, the endotheliitis, which is some of the vasculature is impaired, and again, that's also kind of a pro-inflammatory type of thing. I think probably at play are other major systemic abnormalities, such as the hypothalamic pituitary axis, diminished cortisol responses, and neurotransmitter impairment, such as low serotonin levels, all of which, can cause prolonged fatigue in these patients.
No, okay. I have now two questions. One is, can we get the CDC materials or resources in Portuguese? For example, Medscape in
Yes.
Portuguese? Or,
I
it's
think
a very
mine's
tricky.
still on. Mine's
It's a very tricky question, but
Right.
it's
Well,
not
that would be
mine.
wonderful. That would be wonderful. We did translate them into Spanish for our population in the U.S., but we would need assistance probably. But that's if you need them and want them, I think that's definitely doable. Yeah.
Oh, thank you.
Yeah.
And also for you, Elizabeth, what precautions should I take to be able to do activity and not have pain, fatigue, brain fog, and diarrhea? It's one of
That's I can't answer that one completely. I would say that the precautions that the patients have learned over and over again it's very hard to live with, but they need to understand themselves. And I've had different people explain it different ways, thinking of an energy envelope or a certain amount. They have a certain bag of pennies, and they can spend their pennies only a certain way, and then you're out, right? And then you go into debt, and that's when you run into trouble. So it is this pacing is another way of phrasing it. It's very, very difficult to implement because particularly with the disease being relapsing, when you have a good day, it's natural to want to go. And that introduces the problem of sort of the next day crash. And so you want to try to avoid that, and it really is the best answer that we have. Now, as far as the dysbiosis or the irritable bowel, that's a poorly understood even condition all the way around. People are hopeful that understanding more about the gut microbiome may help that, but it could also be an autonomic problem. So we just don't have really good answers. I'm very sorry.
We have not complete answers, of course. Any other question? If not, okay. Last question. We are just in time for one.
This is
question, please.
This is for Dr. David Sistrom. So you're talking about the high pulmonary blood flow and the low extraction groups. I was going to ask if there's two things you looked into. Oh, sorry. Okay, this is better.
Okay.
Yeah, sure.
Repeat it, please.
Okay, so the high pulmonary blood flow, low extraction groups. You're saying about peripheral left to right shunting. Were they tested for a partial anomalous pulmonary venous return?
So great question. I did not say, but all of them at the time of their resting right heart catheterization have what we call saturation run. So we look at the SVC saturation, the right atrial saturation, right ventricle, and the distal pulmonary artery saturation. So there we are looking for intracardiac or partial anomalous venous return would be loosely included. any evidence of intracardiac shunting, and we never find it. But great question.
If there are no more questions, we are going to have now another? The very last question, okay.
Last one. Another one for Dr. Systrom. Besides the mitochondrial myopathy, are there other conditions that seem to have the similar results? And I'm also wondering about deconditioning. How does that compare?
So really good questions. Impaired systemic O2 extraction, I'm going to try to answer both questions with one answer. Impaired systemic O2 extraction, interestingly, is not a feature of simple deconditioning. And that was shown way back in the day with our Scandinavian colleagues at the Karolinska, putting athletes to rest and doing replicate invasive CPETs. And the major feature of detraining is a decrease in left ventricular end diastolic volume, stroke volume, cardiac output, but is not systemic oxygen extraction impairment, strangely. And that's been replicated. Peter Wagner has done a nice review of that in the last 10 years or so. So deconditioning, though, affects every chronic disease that I've ever met, and it sure doesn't help things. What's unique, of course, with both ME and a subset of long COVID is post-exertional malaise, and we address those issues. We don't have the great answers for that. Honestly, and I know this is intensely controversial, hand up here, we do not simply send people back to the gym and tell them to work their way out of it. That won't work. Everybody in this room knows that. Our hope is that we can properly medicate patients, get them to a place where they can resume more activity and eliminate at least part of the deconditioning confounder.